So we're going to talk about Macra. And and again, I want to thank everybody, Marion and Bill Bosby, and everybody who helped me get this thing up, and I think it's going to go just fine. I'm going to get into all that. Thank you. So this is exactly the way you and I grew up. This is what I grew up with, and I actually have this photograph, this photograph in my office. And as you can see, there's a pharmacist, and there's a little boy waiting for the pharmacist to create some sort of concoction for he's not feeling well, and he's looking up to the individual, the professional. You have a doctor over here getting something ready, and this young man's looking at the diploma. Again, the dominant form is, and the biggest form in that is the physician. And over here we have a gentleman, obviously a family practice, general practice, who's listening to the heart of the doll, and this little girl is very concerned because she's feeling bad, so it's projected on the kid, and those of us in the medical business understand that. But you notice how it's dominant, and the two professions in the United States and around the world, the two people that are trusted very, very high, 1, 2, are pharmacists and doctors. Okay, that's what we grew up with. So, just a comment. Government create wealth the same way ticks create blood. So let's get into some of these rules. There's a young lady who painted this and presented it to one of our friends at the AMA, and he got it on the front page of the JAMA. And if you want to see it, it's on the internet. This is a 7-year-old's patient's picture of a doctor's visit. Notice where the doctor is. Little bitty guy in a chair looking at a computer. That's our life now. Right, Howard? Bruce, you don't count. You're retired. But anytime you want to come back, that's what our life is. No desire. You hear that? We love our profession. You will not find any human being here in the United States more dedicated, more committed to serving you and saving your life. I got a call yesterday, a patient who said, well, you know, I want to go over here rather than over here for my aortic valve. Hey, I want him happy. Who's the surgeon? I said, okay, fine. As long as it's a good surgeon, you're going to be fine. Because you can literally fall in any hospital in Houston. This is Mecca, and you're going to get good people. But this is her interpretation. And here's the patient, and he's looking at us. He's not looking at the doctor. Remember those other pictures? So this is a 7-year-old's viewpoint of her world when she goes to a doctor. So the definition of Macra is the Medicare Access and Chip Reauthorization Act of 2015. And when that was passed, your Congress, our representatives and senators passed it. The president signed it. We were happy about it. I was asked to go to Washington. You all seen the picture. It went viral. I shook President Obama's hand, thanked him for it, because we wanted to eliminate the SGR. The SGR was the thing that had been developed about 17 years ago and had been a bane in our existence, taking care of Medicare patients. Because every year it would renew, and the amount of discount to seeing a Medicare patient kept getting worse if it ever passed. Finally, after putting up with this for 16, 17 years or such, they decided to rescind it. That's not going to work, because we want to take care of all our Medicare patients. So they eliminated it. But in the meantime, they created this new, and it's in quotations, incentive and penalty programs. And at the time we said, well, we've already got meaningful use in PQRS. So all right, fine, we understand it. You're going to refine it. So that way it's less onerous, less draconian, not so hard, make it easier for doctors to communicate to whoever it is that's paying us what it is we do for a living. So they drafted and implementing rules for the new merit-based incentive system, MIPS. You will hear your doctors talking about Macra, which is they're effectively talking about is MIPS, M-I-P-S, merit-based incentive systems. And at first we start thinking, okay, well, if I do a good job with taking care of my patients, I'll get some sort of reward for that, okay? We found out a little bit different. The intent from Congress was first to reauthorize the Children's Health Insurance Program, CHIPS as it's called, for 2 years. Didn't have a problem with that. We removed the threat of the SGR-driven Medicare payment cuts. We agreed with that. And it promised to simplify the federal regulations that are strangling physicians' practices in our offices. If you go to breakfast, if you go to lunch in a doctor's dining room, you will find that all of us are complaining about this particular problem. The rules and regulations that we are dealing with right now. Then this last May, the CMS, which is the Center of Medicare and Medicaid Services out of Washington, it's actually in Baltimore. I did my residency in Baltimore. And it's a huge, huge deal. Let me tell you, it is huge. They publish these rules that are actually more costly, more complex, more confusing, and more damaging to small private practice. Now, there's some of us that are one. There's some that work in two. There's some, like Bruce, before you retired, small groups, okay? What do you think the percentages here in Texas alone of this kind of thing, onesies and twosies as we call it? Almost 70% of the state is small practice. It's not these big clinics. We all think of it as big clinics here in Houston because in Houston everything's bigger. But having come off my tour of duty as your president of the Texas Medical Association, it's shocking. There's people in little bitty Cotulla, Texas, and they're all independent. And let me tell you, we're talking capital I independent. They're very, very, very suspicious of rules and regulations coming out of somewhere. So many of us here in this room and many of my physicians are like the millennia. We don't take to this authoritative dictates that are coming out of Washington. We have a lot of problem with that. So these are the pain points. I'm just going to go over some of the highlights, and then I'm going to get into the weeds. So Clay, hang in there, man. I know it's tough. I'll get you a little Ritalin to keep you going through this, okay? The first is CMS created more complex, flawed point system with flawed concepts from already complex quality programs that are already currently enforced. So this point system is going to be where Bruce and I and Howard see patients, and we're all going to start competing with the three of us to get points. So that way I get paid more. Wait a minute, I thought I was supposed to take care of you, Clay. I thought your doctor was supposed to take care of you. That's not the way it's set up. We have a problem with that. This system is damaging to the solo and small group practice literally in its first year of implementation, and I'll get into the specifics on that in just a bit. Here's another one. The current plan proposed will not streamline the current quality reporting systems nor simplify the transition to value-based care. That's what they want us to go. Value-based. Not, I see Howard, I do an EKG, and I get paid for it. The words that you're using now, and those in the insurance industry have heard this already, population health. Population health. So the average age here is what, about 32? So the insurance industry will look at this, and by the way, it's been sanctified by our attorneys who say, oh yeah, this is okay. All of you are part of this group, and these are the doctors you're going to see, and you got to play by those rules if you want to have this coverage. That's the way it's going to be. Population health. It's not that individual thing like I showed you in that first picture. It's population health. Now, this costly reporting and compliance, this is going to be something that we're going to be hearing a lot of in the coming years. This reporting is costly. It's very expensive. I want to thank Dan and Bill and everybody else, Myron, who set this thing up for me, because literally, I know how to do it now, but when they forced the physicians to do it, we were really kind of wondering. I thought I wanted to be a physician, but now I have to be an IT person. So you don't need to worry about retiring from IT. You will have a job for the rest of your life because there's physicians that are still having issues with their electronic health medical records. We already know it's expensive. I have colleagues of mine, and Howard, you've heard the stories in the lunch counters, where they have bought software, hardware, and literally within 4 months they have to throw it all out and start all over again, right? Software that's not kept up with the changes, and yet we're held responsible for that. The additional new programs we estimate will cost $128 million. Out of the federal government, how many times does that number go down? It usually goes up. There's disjointed timelines. I'll get into this area right here. If you make a mistake driving down Westheimer, you have to fix your mistake right away. Too far to the left, too far to the right, whatever, right? The timelines here for this new system coming on is I see patients today, I saw the Houston patient today. 2 years later, they come back and say, Tom, you didn't do something right for Greg, and you could have done a better job on. 2 years later. You think how many are going to remember that encounter 2 years later? Now, with the number of patients we're seeing today, and the numbers are going up because people are seeing this, my colleagues, and they're saying, what do you think they're saying? You're all businessmen. When it gets too onerous in a business, what do you do?
Shut her down.
Shut her down. Where were you just now? In India? Why? Because things in China look a little bit different. You might have to move your sources to India. That kind of stuff. We, as businessmen, I've heard your conversations. I've heard your presentations. And do you think we're any different than any other small businessman or person? We're facing these consequences of these guys coming right at us. The metrics. There are metrics that we have no control over. Can I control a patient if they happen to be poor or live in a geographic area that's where they've always lived? And yet a physician moves to that area and takes care of them. He will be penalized for that. He has no control over those demographics. What about the vendors? They're the ones selling it to us. Man, they're going, hey, man, this is time to make money. By golly, we're going to get those doctors, and we're going to sell all this crap to them. And that's what we've been getting, a bunch of crap. And the federal government's holding us responsible for their deal when we have no control over it. That's kind of like Wall Street, right? You can control what's going on in Wall Street, right? The bond market, 2008, anybody remember that one? These are,
What do you mean by
vendors. Anybody who sells me anything, hardware, software, anything that sells me to help me do a better job for my patient, they're off the hook.
You're not talking about big pharma.
Oh, don't even go there. Did you see the thing yesterday about the hospitals having trouble making their budgets? Now look, their margins, what, about 2.5%, 3%? Kind of like HEB, 1.5%, 2%. But their numbers are humongous. You take the division of HCA, that 1 or 2% is a huge margin. And when pharma goes up, kind of like the epinephrine, remember that one? And they're still talking about it, Bruce, this epinephrine thing. Oh, they're not out to make money. They're out to make a lot of money at your expense. And by the way, you can go over to Mexico or Canada and get it at what price? You all know that.
About 80%.
Did you hear that? You walk across that bridge, and let me tell you, that bridge keeps getting wider. The people who park on the United States side walk across with their prescriptions and come back with their medications. It's happening. People are going to be making choices like you have no idea. These are some of the timelines. The fee updates are for the next 4 years, and then it's zero. Really? Bob, can you make those kind of projections in your store across the way? What happened when your rent went up? You start looking for other ways, right? Where does a doctor go? Where do we go? What do we do? I want to, COLAs, something as we go forward. I need something, to account for increased expenses. You're making me buy all this hardware and software to take care of you. How can I get a return for that, right? You know what I'm talking about. You have to make more tents. Can you find a place where they'll make cheaper tents but same quality, right? Or a flashlight, whatever. That's what I'm getting at. So the MIPS will go up 4%, 5%, 7%, 9%. But underneath that positive, there's a negative. It could go up or down. That's the penalty side of it. And then this alternative payment schedule is only 5%. Can you imagine starting off your business and you're telling, okay, you're just going to make 5% forever. That's it. You got to figure it out. What do you think a physician's going to do? And then there'll be additional funding. This is what they're telling us. $75 million for quality measure development. I don't know what that means. $100 million for technical assistance in small practices. We're talking about 1.3 million doctors in the United States. $15 million for quality measures again. $500 million for extra MIPS bonuses. What do you think they're trying to do? They're trying to herd all these. Man, I'm from South Texas. When you're herding all these cattle, where are you herding them to? The slaughterhouse? So we're going to start going into some weeds, and please forgive me. I'm going to go over it a little bit, and then I'm going to show you 2 videos, and then we'll call it a morning, because I know you all have questions. I mentioned this thing about 2 years looking backwards. That's what they want to do, because they want to analyze this data. What are they going to do with all this data, all this stuff? They're going to be knowing who you are, what you do, where you live, what you eat, what kind of medicines you take, how many tests you're ordering, why aren't you doing this, why aren't you doing that? Population management. You see what they're doing to you? If they're hurting the doctors in one area, what are they going to start doing with patients? They're going to start hurting you. Come on, everybody. Get over here, little doggy. Let's go. You know, you can hear it. And the penalties. I have never seen a situation where it's so draconian. I mean, okay, if I'm doing a business and I want to make a little bit more money, you do what Marion does. He went to India and he's keeping his options open, several lines onto your bow, strings, and that kind of thing. This is not what it's set up for. The way they're setting up for it is they're going to penalize you. They're going to penalize you because we want you to do that, Tom. Don't do this. We're going to penalize you. And they keep penalizing you and keep penalizing you until finally, doesn't that sound like a cattle prod? Until this is what we want you to do. This is what we want you to do. We don't want you to have an independent thinking ability when I'm listening to my patient when they're telling me what their symptoms are. Remember what we were told, Howard? Listen to the patient. They're telling you the diagnosis. Now I have to listen to the patient and feel the cattle prod. Okay, this is what we want you to do, Tom. Don't order too many tests. Don't do this. Don't do this. Just keep costs down. And if you don't, you get penalized. And here's the other thing. They want you to keep costs down without any evidence of improving quality care measures or increasing efficiencies. There's nothing in there that shows that that's going to give you the outcome. In the scientific method, we look at the outcome and then we adjust the experiment to get what is it the outcome we want to do. When Howard and I and Bruce are looking at a patient, we're doing what is the best outcome I want for this patient. Like that patient who called me and wanting to know where he wanted the aortic valve. I want the best outcome for him. They're not taking that into account. So here's going to be a little bit of an outline for reconsideration. We're suggesting that you exempt those physicians, and patients actually, who have no possibility of earning more than it costs to report the data. Do you know if they don't report it, you get penalized, and if you report it and you don't make a certain level, you get penalized? If you're living in a place like Mesquite, Texas, no, that's not a good one. Cotulla, in the middle of nowhere. Van Horn, Orca, Texas. I mean, there's no way you can compete with Tom Garcia in Houston. The numbers don't match. So the smaller the number, the more likely you are to get penalized. So you need to exempt those physicians who want to do the right thing and participate and report that, because they want that data back too to see where they are with their peers. In addition, we want to establish objective and timely measurements and reporting systems that are simpler and less costly. And we think, at least in the TMA, we think we can do that if they'll just listen to us. Use quality measures that capture those activities that are under physician's control. We know, in my practice, I know some of the things that I can do. Blood pressure management, blood sugar management, cholesterol management, weight management, getting a person to stop smoking. That's something we can measure and watch. And that's something I can recommend. I can't control the patient in what they eat, how they live their life, and whether or not they're going to smoke or not. There comes a point where how far do you push the responsibility of the patient, of the physician, to the patient? So doesn't that sound interesting? At some point, the federal government say, well, if these are your choices that you're making, gentlemen, and what you ate today, there's going to be consequences 5 years when you're asking for help. Again, population health management. Allow physicians who want to make the shift to value-based care enough time. They literally want us to do it literally now. In my opinion, they want us to do it now. And the way the system is set up, you remember the first picture I showed you, is when I walk in, it kind of bugs my staff sometimes, I spend a lot of time talking to the patient and listening to them, making sure I've got the right number of pills they're taking that's giving them the right outcome. Remember you were asking me about the statins this morning? He was asking me, you know, are statins out to just destroy our muscles? No, the 4S study showed it clearly. The outcome is you don't want to have a heart attack or a stroke and die. And we did that with demographics with very young people in the Air Force, right here in San Antonio. There was another one done in Stockholm. These two studies clearly demonstrate, and it was replicated repeatedly that they help. So those are the things that we can do, but if we're going to continue that, how do we shift over to this value? Population management. And then require the EHR vendors to be on the hook for it. Now I'm going to go over some other things that now we're going to get into the weeds of what we're going to recommend from the congressional side and from the rulemaking side. We want them to remove all penalties and the requirement for budget neutrality. We want them to remove all administrative requirements that are not supported by evidence, and we want to require CMS to set the performance at 15%, not at 85%. You don't start off with such a high number. That's almost unachievable by the vast majority of our physicians. It's almost impossible. And then we remove this composite score and minimize the requirements for the penalties. In addition, we have this proper risk adjustment for all cost and quality measures. Remove those known correlation, especially with demographic variables. If a physician's in a poor area like in South Texas in the Valley, you can't penalize him just because that's where he lives and those are his patients that he's caring for. Any more than you can compare my practice here on the West Side to someone on navigation. It's just not fair. You got to have some sort of parity there. And you remove all requirements as physician must accept insurance type, especially with a downside risk with APAs. Now, this alternative payment method, it gets to be a little confusing for the physician when you're requiring them to do something when they don't know what the requirements are.
Tom, I thought we were talking about Medicare.
That's exactly what we're talking about. This is all these are the rules. Now we're making those.
I thought with the insurance type, I wasn't.
The problem is, Greg, is all my patients, and I have a very nice mix, I have to report all that data, which includes those patients, and now the federal government has it. So instead of just teasing out the Medicare patients, they want all the data. So what does that sound like? Something like one of our candidates, just one payer, that's what we want. And one population, that's what we want. And just one group of doctors. We don't want any independence. We don't want any choices. You see, who is it?
What are they going to do with all this information?
Isn't that interesting? What are they going to do with that information? Let your imagination grow wild. Who's going to get dialysis in the future? When we have our pandemic, who's going to get a respirator? Do you give it to someone who's a smoker or someone who got their flu shot regularly? I mean, these are going to be questions and issues from an ethical standpoint that require a weekend retreat I don't have enough time right now. Now, these are the rules that we want changed. Now, isn't it interesting? Slavic said, these are the rules, these are the rules, and these are the rules. Congress passed a bill with an intent. The interpretation was Slavic said, these are the rules. Who told him that these were the rules? Who told him, Bruce? Who's his boss? Somebody in a White House or someplace? I didn't say that, did I? Someone told him. I wonder where it's coming from. Look, I'm just a South Texas country boy. I wonder what goes on in Washington. Who tells people what to do there? So this is what we're asking them to do. Minimize the ask for a 6-month deferment. Give those physicians who have a low volume threshold a break. Allow us some time to understand this alternative payment model and give us real-time information. Don't wait 2 years for it. Focus on those areas where physicians do have control, and every physician knows what they can control. Performance thresholds, lower to 15%. Simplify the quality performance point system where it's not competition between doctors. It's competition to get better care of our patients and compare those data against physicians to physicians. And then you have education of those physicians who may not be doing the high quality. You get education to them because they may not know that they're not doing it. You eliminate the requirement for all payer data. That's what you're talking about. You eliminate that. Besides, it's none of their business. Really. Reduce reporting thresholds, we already mentioned that, and hold harmless. Just because a physician buys something from Clay doesn't mean I know everything that Clay did and all the research behind his product. So you have to hold the physician harmless for that. He's trying to do the right thing. The vendor may not have the same kind of ethical considerations. And you need to hold them accountable. Now, this is some really tough stuff, so I'm going to go over this kind of briefly. These are the penalty incentives, 4%, 5%, 7%, 9%, all the way into 2022. EHR average is within the first 90 days about 32,000. We think it's closer to 54, 56,000. And then the maintenance fees going forward is around 11,000. You're going to have job stability. You can be a consultant for the rest of your life. Just become a friend of the Harris County Medical Society. Your phone will not stop ringing 24 hours 7. And then never mind meaningful use in CPIA. The costs go on and on. And by the way, I still have to take care of patients. The return on investment, you're talking about not until 2019, we've calculated, we think, before you get any return. And the annual profit, they say it's going to happen somewhere around 21. My comment is, yeah, right. And finally, so my net is literally a negative $95,000 and continues with a loss through 2022. Can you imagine being told now and for the rest of your life, basically for some of us, you're going to have a negative to practice medicine? And this is the cost of reporting all this stuff. You have all these incentives, the accumulated cost, the return, and then the profit. Finally, this is something that might be considered. Truth is like poetry, and not everybody likes poetry. Hello? Go ahead.
Well, it's just appropriate time to ask you a question. I get a sense from listening to your presentation that it is all designed towards preserving the independent practitioner. That's your point here.
From my standpoint, these rules are to destroy family practice. Right. So we're trying to improve it. We want the independence of the physician.
You know, as a small independent businessman, what we see is ever more increasing costs.
Thank you.
And
Same thing.
Well, but my argument is that it appears that the government is trying to control costs.
Thank you.
And you're trying to loosen the requirements, which
That's exactly right. They're
So how
giving.
do we ever get a hold of the issue of, we always, we don't make money in the sunlight like down the street.
Talk to Bob about that one. I have this handout for you. This was a white paper that was developed by the Texas Medical Association. I have them here if you want to read it. I highly recommend it. That's a distillation of about over 1,000-page document, probably close to 2,000 pages. It's about 16 pages. Gives you a little idea. I can send it to you. I'll send it to you by the PDF for anybody who's interested in it. But these are some of the annual cost reporting thing. They tell us that it'll cost anywhere from $84 to $1,200.
But how do we get control of these ever-increasing costs as business?
They're not asking us that. They're just telling, this is what you've got to do, sir.
I understand that, but from my perspective,
How do I do it?
how do we get?
This next slide is what I'm talking about. To do that, this is what you have to do. You have to have the time effort is somewhere we estimate is around $50,000 to do that. But it's out of our pocket to do that. I can't, there's no way I can negotiate with that. It's coming at me for me to report it. So the compliance and the reporting requirements that they have right now, and it may change, they're going to decide this, I believe, in November. The new rules. And believe me, we got everybody's attention. We passed this out at the AMA meeting in June, and everybody was shocked. No one had read what the rules were. What we did at the TMA is we got a think tank of about 15 staffers, went through the whole document and have this as a statement.
Are you arguing that if you get rid of all these rules, our costs are
No. What we're arguing is to streamline the rules. We want to work within the system. I get it that they want to go to this alternative payment model, but we want to streamline it and do what's right for the patient, not do what's right for the government. Go ahead.
Tom, when you say they, now you've got the legislature
Yeah.
passed laws.
Yeah. Yeah.
Who implements them?
That's CMS. That's CMS. That's where the rub is. We talked to Kevin Brady, and he said that was not the intent of the bill. And we had a nice meeting with him, and he's a good guy. He's our friend. He's your friend. And now he's got to go back and talk to Andy and these guys over in Baltimore at CMS and say, hey, look, guys, who told you to make these rules? And can we make it a little less onerous? So I'm going to just finish up on this part here. Just to give you an idea, and this is something where this is where the rubber meets the road. In 2014, when we got into PQRS, we had about 1.3 million that were eligible. Only 800,000 roughly participated. And of those that qualified, look at that number, 600,000 made it where they got paid a little bit. And I would estimate 2 to 4%, something like that, right, Howard? Something like that. It wasn't much, but that's, the question is, what happened to the other half? Concierge, retirement, leaving, being hired by hospitals, being hired by insurance companies, retiring, moving around. I've always wanted to have a tree farm. I want to start my own vineyard. Maybe do a pet store, get into IT. I always wanted to have a restaurant, Lesep, number 2. That's what that question is. Where'd the gap go? So let me just finish up here. These are the rates by performance, and these are what they're the 4 different areas that they're gonna look at, and it changes from year to year. But basically, it's cutting costs. And then the demographics, I already mentioned that. There's disjointed timelines. The metrics that are not in control, MIPS, that's where the Macra comes out, and penalizing those physicians, and arbitrary incentives, which make no sense to us. The alternative payment model, and cost without evidence. We need evidence. And right here at University of Texas here in Houston, the medical school is working hard to come up with some data that makes sense for them. And finally, these metric things. Surveillance. I mean, they're looking, we're asking them to use the University of Texas to help us with this surveillance thing. And finally, this exchange you already saw where everybody's, if you have a small business, your premiums are going up. And after all this, they thought we would just embrace Macra. That's my question to you. What does it mean to you? It means your doctors, in any room, the doctors of the United States are the angriest people on the planet. They are pissed. Because we were trained to be doctors, not to be IT. We were trained to take care of you, save your lives, help women through tough pregnancies, help them with their hearing. Can you imagine losing your hearing, not being able to hear this guy this morning? By the way, that hit on YouTube, that was 45 million and still going. The guy went crazy. Just a double rainbow, you'll hear the whole thing. It goes on for like 10 minutes. I can't think of a more noble profession than being a physician. I did not sign up for this. I didn't ask for this. So what do you think the doctors of any state are going to do? In my opinion, they're going to retire. We're going to look at other avenues of making a living. Some of us are going to be hired by hospitals. Some will be hired by insurance companies. We'll still have to deal with these computers, and I would like to show you what happens to a computer guy. Emma. Yeah, a computer. You don't need paper. No paper. And Emma's going, hey, Sudoku, you can do it on a computer. Everything's on a computer, right? Reading a book. Everything's on a computer. Taking care of patients. Hey, there's your paper. There's your paper. That's what the doctors are telling the government. The government's on the pot, and he's asking, where's the paper? To this day, I'm keeping all my medical records. Bruce, Howard, all of it's still in paper in my office. Why? I don't trust any vendor. One of my colleagues during you know about the story. I got a call from Laredo. One of my colleagues said, hey, I went home for the weekend, came back. There's this blue screen, and it says, pay me in Bitcoin to get your medical records back. I knew it was going to happen. So I kept all my medical records in paper. Max, all your documents, John, all your documents are safe. They can keep it. They can keep it. Whose fault is it? It's the vendors, right? I still got all your data on paper. I'll just switch to another vendor. Because they're not on the hook. I am for your health care. And that's what I'm here to tell you. The physicians that have a sign that says cash only, they're for you, in my opinion. Go ahead.
Aren't they having problems getting students to become doctors? If they have that problem and you have doctors retiring, are we going to have a real shortage?
We are. You saw where there's literally half of the physicians didn't even make it with PQRS, and now you have Macra and MIPS. Trust me, there's going to be a physician shortage. Who do you think they're going to ask to be signing up for that job? Chiropractors? Nurse practitioners? I did a weekend course. I can do your heart cath. I did a weekend course. I can fix your valve. I did a weekend course. I can deliver your baby. Oh, that's kind of like, you don't want to get a professional to help you through the travails of taking care of your estate. No, what is it? Those guys on the weekend, just come over here. I'll show you how to make a quick buck over in Wall Street. You know what I'm talking about. That's the kind of stuff that we're going to be facing with. I'd like to leave it on this final comment. There will be a group of physicians that are dedicated, properly trained, that are going to be here for you. So that regardless of what kind of population health you may have, there will be a group of doctors that will be here for you. Just as much as we have excellent attorneys, excellent people in the insurance, there will always be people that are professionals. And it's groups like this that network and say, that guy's okay. That guy's okay. He's okay. Thank you all very much. I'll stick around a few more minutes for questions.